here. Again, I'm Ashley Campbell, the managing editor of IJSPT, and we're honored to have one of our amazing sponsors on with us tonight, Digitsole, to talk about their technology, about their product, give us a little example here with a clinical case study. Please feel free to ask questions along the way during the presentation. Just type them into the chat or use the Q&A feature. I'll be monitoring that and can throw them out there. So with that, I'm going to turn it over to Brandon Noble, who is part of the Digitsole family, to give us a little bit of an introduction to our speaker, and then we'll get started. So Brandon.
Fantastic. Thanks, Ashley. Thanks everybody for attending. Really appreciate the time. I think you're going to be impressed with Ivan. So I'm Chief Marketing Officer over at Digitsole, and looking forward to bringing you some really useful content tonight. So I'd like to introduce Ivan Moller from Denmark. So we're really, it's the middle of the night over there. So we can't thank Ivan enough for taking time away from his sleep to educate all of us on a really important topic. So Ivan's a PT physio over there. And I'm going to let Ivan do a little bit more of an intro to himself. So Ivan, at this point in time, I'm going to turn it over to you and let you get moving.
Well, thanks a lot, Brandon. Thanks a lot, Ashley, for introducing us. And thanks for letting me be able to represent the work that I'm doing in Denmark, and also in how we use Digitsole Pro in our clinical way. So the uptake was today to make kind of a case walkthrough or case of one of my patients, and using that to describe how we work, both from a clinical practice, but also how we use tools like the Digitsole Pro in our everyday life. And hopefully I'll be able to give you a kind of insight into this. And yeah, and as Ashley and Brandon also said, please feel free to ask me questions during this presentation. So shortly about me, I'm a physio, educated and examined from 1997. So it's actually quite some years now that I've been working with this. And in 2005, I became an osteopath and finalized a university degree in osteopathy last year in the spring. So I'm specifically specialized in manual therapy effect on running performance in that category. So professionally, we have a private clinic in Copenhagen where we are focusing mainly on what we call active people, trying to help active people sustain active or getting back to an active life. And we work with all kinds of active and sport level, from absolute amateurs to absolute Olympians, and from beginners to more experienced people. Personally, I played handball and football, soccer in my younger days, and now I'm just recreationally doing some running and cycling and swimming with 4 children and a family life with that. It's what it is that you have your time for. So one of the questions that we often use is, why do we actually use the gait and run analysis in our daily practice at the clinic? So with us, we have like kind of 2 primary objectives, both from the customer or patient perspective, but also from our interest of such. It's mainly to injury or comfort or discomfort that people are attending us, but also especially with the more elite sports people, it's also a bit of performance optimizing and seeing, can we twist small changes that can be those minimal factors that actually put them a bit in advance of their the competitors and in other aspects. So we have like these 2 kind of issues that we're working with: injury and discomfort on any levels, but also on those performance optimizing parameters. So how do we monitor these? The headline is mobility, but actually functionality. We do like kind of, we don't let our evaluation become valid from one tool. So we like kind of use a collective evaluation that is primarily based on our clinical evaluation, which is typically manual, but also observational from just our own eyes. And then we see visual observation on video with the slow motion. And we do dynamic evaluation on foot pressure with our pressure plates. And for instance, doing neuromotoric evaluation on one-leg stands, but also using these Digitsole Pro insoles that we have used for the last couple of years now, to actually see what is happening within the shoe in the way they're working. And of course, clinically, we do a hands-on examination, observational. We do these videos, and also with the, for instance, we have a product of a pressure plate from a European distributor, but also the ProtoSmart, actually to sum all these information into one kind of a plan or a structure for how should we assess this patient or this athlete to give them the best advice to find the way for them to reach their goal of either getting out of discomfort or injury or into an optimized performance level. So that is basically the reason why we can use, or why we use gait and run analysis at our place, instead of just treating patient at the bench and then just letting them go from the clinic as such. So it's always a combination of these. So again, who can benefit from gait run analysis? Yeah, who can't? We could do it in sports, in high performance sports, and low performance sports, people who are walking. We could use in the work specific situation, people working in warehouses, standing in cashiers, working as a mailman, or whatever situation where you have a standing or an active work life. It's obvious that you can reach a situation where it will be beneficial for your situation to have an analysis of how your actually biomechanics are, and then of course use the best tools to actually be able to analyze it, supporting your clinical evaluation. And of course in situations where we specifically have physical impairments like orthopedic or rheumatic diseases or other handicaps that can influence your contact to the ground through the feet. So of course, so these are obvious situations where you can use these analyses to have your patients benefit from it. So tonight we will talk about this knee pain case study where we specifically, I will focus on how we use the Digitsole Pro in this aspect. But before we go into specifically the knee pain, and the knee pain from this is a running injury, we would look into the majority of what are running injuries. In this forum, I think most have some kind of idea or some knowledge of what running injuries are, or what the etiology of these are, and what the history and where we are now in regard to evidence, and yeah, how hard it actually is to create evidence. But we have like these three major areas that we are primarily hit or injured in when we are talking about running in both recreational but also in elite levels. So we have the knee, we have the foot, the lower leg, and the hip, thigh, and pelvis in respect from these when we look into literature, and also in regard to my clinical experience, that is typically the knee or the foot and lower leg that we are addressing in the clinic on an everyday basis. But also hip, thigh, and pelvis areas are of course areas that we see people having injuries in or discomfort in, but specifically also areas that we definitely had to integrate into the understanding of why people have these kind of injuries. But this is the typical areas that we see people having injuries, both from what is researched in literature and also in the everyday practice. I think most sports physiotherapists will be able to recognize and agree on this. So there's been a lot of discussion throughout the years, why, how, and what are the reasons for getting these injuries. And the latest, and I think for the last decade or so, I think the arrow has pointed a way into a more broader perspective of why people get these injuries. Now I've been a physiotherapist for almost 25 years, and I think in the beginning we were very focused on the golden rule that could explain why people are getting running injuries. And I've been in the game for so long. I've been through the maximal shoe, the minimalist shoe, the new functional shoes, and all sorts of stuff. Strength core training, not strength core training, flexibility, whatever. There's been so many solutions and ideas on how to address the more deeper lying etiology of why people are getting these running injuries. And I think what is most common logical sense is also what is actually coming into literature now, that it is very complex, if you could say one name to it, or multifactorial. We have things like anthropometry, anatomical, biomechanical malalignments that you have with you from birth, or that you have given to you by injuries or accidents, or things that have happened or occurred in your life or your lifetime or span of life, your body mass index. So all those kind of structural or things that are as a picture of who you are in your state of mind, as it is as now, the functional capacity of your mechanical body as such, if you could say so. And then of course you have the training. How much training do you do? What is the intensity, the distance, the actual overload, the overall load that you're given into your body. And then you have the ever ongoing things that is almost always coming up in any article, that you're saying that if you had a previous injury, you are more susceptible to having a new injury. So of course, previous injury that treated or not treated, well, not altered or not fixed yet, can definitely still have a situation of influence on a new injury. So of course, that's mainly simple logic. And then of course your personal data. How is your stress situation? How do you sleep? What is your diet? And so on. So a multi-perspective, multifactorial point of view to actually look into these injuries, that are saying that we can't figure out one situation, but it's a mix of all sorts of situations for the specific individual person or runner that are getting these injuries. So that is where we are now. So it can be, as mentioned, a lot of different things and supporting each other in the reason for your specific injury. That is the major take on it. So introducing you to the patient that I have in my clinic since last spring. She is Lone. She is 30 years of age. She has office work at everyday life. So she is not really standing a lot, but working at an office, but a very physical, active runner in general. Normal weight, body mass index as written of 22.2. She's very experienced and as a recreational habitual runner at the higher level. I think as a recreational habitual runner, running in optimal situation around 200 kilometers a month. And actually running is just not running as running itself, but running for her is a part of her social life as well, as she's a very integrated member of the Adidas running community, the Adidas runners. So for her, running is both a physical, but definitely also mental and social aspect of her situation. So when she came to us, specifically in regard to the left side, the running part of it, it was her left knee that had these unspecific knee pain that was lasting more or less for a year, not taking her away from running, but bothering her while running and giving her this discomfort that we were talking about. So when we look into the clinical approach at our facility and our clinic in Copenhagen, we kind of take, when we look on the very specific mechanical functional aspect and not psychosocial things, like, as for instance, that it's very important for her to run regarding the social thing, but the very mechanical and very structural physics situation, we kind of have these three pillars that we are looking into, where we have the extrinsic factors with the structure and the physics, the world of Newton, that we are kind of addressing and saying, well, gravity is what gravity is, and gravity is really one of the big things that we are struggling with, especially with running. And then we have the intrinsic factors, which are the integrated functionality of your body. So we have these external forces, and we have this integrated functionality that kind of has to, in a mathematical way, to be in balance, more or less. So if you have like kind of disintegration of your functionality and an increased load of such, we have this kind of situation where we kind of have a struggle that potentially can give these running injuries. So it's both in a didactical way to explain both from our patient, well, especially with patients who have this symptom mind thinking that, oh, I have this iliotibial tract syndrome, or I have this kind of diagnosis on me. I was saying, well, regarding to running injury, it's most of the time it's really related to something externally structural and something internally intrinsic that are kind of off balance. So that are the two major perspectives that we should kind of bring those together in a balance again. But then on the outskirts of this, we have this habits and behavior. So one of the things that we see both empirically in the clinic is that people tend to understand that, well, we have these extrinsic and these extrinsic factors that has to be aligned, but making them able to actually integrate the ideas and the exercises and the behavior in everyday life, and talking into those habits that they have and they might need to change, that are some ways and sometimes often the most problematic part of the therapy. But that is the understanding of that we have these three pillars that are as such very well integrated into one. So when we look into it, we can separate them, but we have to accept that they are always very well integrated into each other. So, but when we do that, then we get this kind of individual whole-centered perspective, as we call it, where we kind of look around the whole perspective of the situation. So we understand and accept that there are these extrinsic and external forces. We have to investigate our aim is to investigate the very raw mechanics and the functional capacity of the running body, putting the patient into a very mechanistic world, which is maybe not the most, if we only did that, that wouldn't be very modern physiotherapy as such, but we have to, for that specific chapter, look very specific into the mechanics. But then of course also accepting that we have these habits and behavior, and we have the whole psychosocial and pain reflective neuro pain science organ that are emerging everything or surrounding all these patients that we are having. So this is how we kind of try to access all these patients. Some needs more whole-centered, some are more straightforward and can understand and be worked very mathematically and very mechanically with. So if we go back to Lone, just to take a bit of history, taking on her, she came with not only just the actual left knee, she had a multiple issue with neck pain, headaches, shoulder pains, and all that, kind of struggling with her, a right hip that was tight as well, and a lot of imbalance in your body, if you could say so. And that was the first visit in May 2021, where we found these several regions with restrictions. As I said, feet, functional pelvis, neck, upper thoracic region, and shoulder girdle, all were mixed up in a kind of tensegrity that was just giving her really bad discomfort as such. But specifically around the left knee were these issues that were related very much to her running. The other aspects were more related to everyday life on the office and sitting and working. So what we did was we took her into a very mechanical and approach on the bench, and worked with osteopathic techniques, physiotherapy, training, modalities that she could use in everyday life, and gave her kind of an immediate release on the functional level. And it gave an immediate positive effect. In only a few treatments, she was really functioning again. It's like she kind of went up to the surface and could breathe again. And actually also had a fine reduction in knee pain. And we agreed to say, well, now it's the summer, it's holidays, and we will go on and we'll see how it evolves during the summer, and you'll give me some feedback at the end of this, on the other side of the summer holiday. And actually, time went on, and I was, no, okay, maybe it was just the Harry Potter trick I did, and everything was fine. But then after 5 months, she revisited me again, still okay functioning, but the left knee was still struggling with her. Not like in pain, but this is not really working as it should be. It refrained her from doing the 200 kilometers a month, but maybe just giving her half or 3/4 of the amount and the intensity and the happiness of actually doing the run. So in the beginning, at the first treatments, we were really focused on, well, it was so obvious that there were mechanical issues, so we just did the clinical reasoning on the bench, and we treated her there. So we decided on her revisit here to go a bit more further into the analysis of running and gait using the Digitsole Pro, and also video analysis and the aspects that we have in everyday life at the clinic. So we did a running analysis of Lone, and that, together with the clinical reasoning from our history of having her in the facility, gave us these bullets that we were looking into. So first of all, she had this prolonged period of a hurting left knee, which was 1 year before she met me first time, but then again better, but still struggling with it. We had these compensatory patterns that we treated, but it was not optimal. So we did the video and the Digitsole Pro analysis, which indicated these mechanical and technical issues in relation to running pattern and technique. There were some things that we could observe both in running when we took her into the slow motion video, and we could see that. So what we saw was a very specific heel impact and a very clear overstriding problem that was actually surprising me a bit in regard to how much she had been running before, but maybe also one of the specific points that could explain why she had these knee injuries. So from my point of view, we often see with overstrider runners, we tend to see more knee and hip issues, and with more flat and forefoot runners, we see that it's more foot and rear foot or lower leg issues. I think that is also very common in other practices. What we saw also was that there was this low cadence, so she was really bouncing from one step to another, metaphorically speaking, but with a heavy heel impact, and this overstriding was really the major takeouts on the analysis that we saw, which was confirmed by the Digitsole Pro analysis. So going on, this is a clip or a screenshot from the Digitsole Pro dashboard, where we get the information in to explain her from to explain and to also observe from the examination. So what you see here is that Lone, at the first visit, this was the first revisit 5 months after she visited me first time. So this is the first one on the 14th of October last year. And she had previously run for all her time in, as you remembered, in Asics Gel Cayano, which is a very stable shoe and very conservative shoe in regard. I think they are on version 30 or so, or close to. So it's a very successful, and for some maybe known as the world's best running shoe overall. But people would probably agree or disagree a lot on that. But anyway, it's a very conventional and conservative shoe with a heavy control on specifically the pronation. So what we saw here, that gave me some interest in her pattern of such was that what we see is the heel impact. She didn't have really massive asymmetry as such, but what we saw was that the strike pattern had a very high heel angle. So her strike pattern was very lifted on the attack angle of her immediate strike to the heel. So what we did to kind of work with that, we did a secondary measurement with some of the shoes that we are actually having to sell out from the clinic. So what we've done is that we are collaborating with the US shoe brand called Altra. And why we're doing that is we actually also have a few New Balance shoes. So what we have in the clinic is like we have 4 shoes. We have New Balance 860 and 880, which is a very conservative, traditional neutral shoe and stable shoe. So that is for patients to actually have the feeling, and we can observe how are you running in a very conservative 12 millimeter drop shoe with support or non-support. But then we also have the Ultra, which is 0 millimeter in drop. And for those who don't know it, the drop is the difference between how high the heel is compared to the forefoot. So Ultra has 0, a difference between how high the heel is and how high the forefoot is. So my idea was already with the very massive overstride and the very clear heel strike to actually what could we address that in some way. And when we put her into the Ultra, it was an Ultra Paradigm 6 we gave her without any instruction, just said, well, could you please try and walk and do the same run in these shoes. We immediately altered 4 degrees of her heel strike angle when she ran in them. Of course, this is immediate impact that she just tries them, so it's of course a bit biased on this new shoe. But what we saw is definitely that by changing only just the shoe that she did to a more progressive shoe in regard to drops, we could also alter the dynamics of how she was attacking the ground. So that was for me the first thing where you can say, okay, here is something that we can use maybe as a tool to help her in some way. So this was on the first visit. This is the same visit where we can see how the trajectory of the pathway. So in the left, you see the running analysis of the gel Cayano, and on the right side, you see the running analysis of the Paradigm 6 from Ultra. So what we see is the situation of how she's running through from the trajectory of heel strike, foot contact, and then the propulsion of getting off in the running. So what we see in the left side is a very, very fine and controlled line, which is actually what the Cayano is supposed to do and what it also gives. What we see is that the center line is the median or the average of all the steps that she has taken, and the lines on the sides are the standard deviations of every step she has taken. So as you see, the left foot is very perfect. Every step is always the same, and the same counts for the right side with a bit of a more variation in her striking pattern. But this is really a smooth and very reproductive running pattern she has given. What you also see is that when we look into the degrees of the ankle when she strikes with the heel, you see that the angle of her left foot is -4.1. So she's actually in a lower degree than on her right side here. What we saw is that when we examined her in the beginning, and also what we were doing on the way, is that she had an issue around her left or around her right hip, which gives her a bit of external rotation on the hip. And in my opinion, that is probably the reason why her external rotation from the hip gives her or goes all the way through the mechanical access down to the foot on her impact on the foot strike, and that is what gives her the impact that is or the ankle that is a fair bit higher on the right side as such, but it aligns. And then we go into the propulsion phase, where one of the things that we saw was a kind of a whiplash that she did when she was propulsing, propelling off. She was giving kind of a whiplash with her foot in internal rotation, and that could, when we saw it on the video, we could really clearly see that her left lower leg was giving some kind of twist to the knee, whereas the right lower leg was just going straight ahead. And that is what we are seeing on the propulsive side here, where we have a kind of accelerated angle on the left foot compared to the right foot, and that is also reproduced in the situation where we see it down here. What we see also, and what was interesting and I will come back to that later on a 6-week follow-up that you will see later, is that when we gave her a lesser stable shoe, which the Ultra is, the Ultra Paradigm 6 is somewhat stable. There is a guideline that gives you some kind of support during the running, especially for the pronation. But it's not a stable shoe at the same level as, of course, the Asics Gel Cayano. So what it also revealed is that when we remove some of the external passive support from the shoe, she actually some kind of maybe lesser control of her actual balance and support in the foot emerged from this. So we see the standard deviation on the left foot actually kind of increases compared to when she was doing the Cayano. So that was some of the interesting immediate observations that we did from the Digitsole Pro analysis, and those were compared with the video analysis that or confirmed by the video analysis, and also the clinical practice that we have done in the room where we examined her both in the beginning and also in regard to this analysis. So already here we had some ideas that we could actually do to give birth to an idea of how should we intervene with Lone in kind of trying to help her in a situation. Because what we saw is, again, as I mentioned in the beginning on these running related injuries, we don't have like kind of the golden problem that we should just fix. And I think for Lone's issue or case, it was the same as we saw and as is described in many literatures and articles regarding running related injuries. So what we did was that we made a plan, and we say for the next 6 weeks we will do a summary of interventions, or a full perspective for interventions, because the analysis that we did with the video and the Digitsole Pro was not something that I did for me. She is always, or all the patients are always integrated into this, because it's also a learning process for them to actually see, well, my boldest goal in this professional life is actually to make my patients or my customers aware of biomechanics, of the situations, to learn about anatomy and physiology, because if they understand, it's much easier for them and for me to actually grasp a process and actually make it more sustainable as such, instead of me just giving exercises and say you should do this because I'm so clever and I know that you will become better from this. What we see is often that people they just get rid of it because they can't remember it. What kind of exercise, how should I do it, and how many times was it, and then they just maybe write once and then but if we can get them to understand, then I think that the associations that are going up in their brain makes better results on the long term. So getting back to Lone, the conception of idea to intervention was that we gave her 6 weeks of period. We gave her the awareness of the current potential issues that we saw from the video and the analysis. we built in a new running strategy, tried to build in or in the small beginning of a new running strategy. We showed her the clear overstride she did. We explained the etiology of injuries regarding to the knee as such that could be related to a clear overstride and a really heavy heel hit to the ground. So what we did was in this process said, well, try to work with increasing your stride frequency. So she was giving the number 165. We talked about how to use her Garmin watch to actually measure how to use it, giving her small exercise on that, trying to do the small shorter stride exercises. What we did also that saying, well, one of the aspects of having a high heel drop in relation to a low heel drop is that the low heel drop can actually make it easier for you to take the foot and bring it under your body to actually assess the idea of a shorter stride and thereby increasing your stride frequency. So, and as there was a good comfort for her in the Ultra Paradigm 6, she bought it and she brought it into her running process. You could argue that going from ASICS Gel Kayanos 26 to an Ultra Paradigm 6 is a big leap, but where she was in a recovery state and she was really willing to actually do these things. So it went all well. And from the Ultra models that there is, the Paradigm 6 is definitely one of the more stable ones. So it's definitely one that is to be chosen if you're going from, for instance, ASICS Gel Kayano to another functional shoe like the Ultra shoe. We gave her specific strength, coordination, and balance training for her functional pelvis. Functional pelvis is a functional understanding of the relation and the working together of the lumbar spine, the pelvic, and the hips in an integrated unit. And of course, also the lower extremities. So balance, one leg stance, squatting, generally the posterior line training, but also just giving her non-specific gymnastic exercises in general for improving general motor control and strength in regard to that. For instance, in the beginning, she came with us with neck issues, shoulder issues, having a work life in office and stuff like that. So clearly trying to assess the whole of her everyday situation, but specifically input to the running and the trying to change those patterns. And of course, even though we are not very fond of it, but giving her also a reduction in general training load to give her time and giving her the right context to actually be able to work with these things. So after 6 weeks, she came back and visited me again. This was November 25th last year. So this is a couple of months ago. She was, one of the first aspects is that she was better. She was not perfect, as she said, but she was definitely getting better. She was in a good working process with getting acquainted with the shorter striding, the higher frequency, but she was really struggling with it. And that is also what we see from literature, that, for instance, when we force people that are heel strikers to go into midfoot or forefoot landing, we see what originally was thought to be, this is the most or the best running economy that you can give, or you can get the best running economy from using the whole foot and landing on the midfoot and the forefoot. Actually, what is seen is that they increase the running or the running expenditure, or the energy expenditure in running is increased when you're going from heel strike to forefoot midfoot, because of the neuromotoric efforts that are done are using so much more energy, and all your viscoelastic rebounding is not sufficient enough in the beginning. So this made really good sense that it was difficult for her. She was struggling with the technique, and she was feeling struggling with it, but she was feeling confident in the process, which was the most important. And what the top most important thing, that she was actually feeling that her knee was responding very well to the process. And what we see is at this left side. This is only done in her Ultra Paradigm 6, this measurement. She has actually kept the lower heel strike pattern at the insert. So a very, very symmetric landing grading of 14.4 degrees on each heel. If you, maybe you remember, but she also decreased, not a massive amount of kilos on her heel strike, but she reduced a bit. But actually reducing the angle of degrees by like 15% of total angle in a strike pattern in the beginning with the Kayano 2, where she was now with 14.4 degrees in both sides. What we see, and what was really interesting, and as I mentioned before, is what we see now is actually that one of the things that we took out from this second visit is that when we see into the standard deviation of the I don't know what happened here. I'll go back to it. I hope you can hear me still.
We're good. We can hear you.
Great. What we see here, and what was a remarkable thing, is that the standard deviations on on her left leg has actually increased from a general perspective. So what is to be argued is that from where we are here at the 25th of November, one of the key aspects from her, and what we visualize for her, is that she really has to work on her balance and control of the left foot. That is probably the outtake that we can take from this. I don't have a specific result that says, oh, this is this, but a general conclusion must and will be, and was the conclusion for her, that she should indeed keep up her work with the stabilizing training and the balance training for specifically her left foot, when we actually look into the specific measurement here, which is actually poorer than it was 6 weeks previous from this. So that is some of the flaws of getting quantifiable data. Sometimes you are challenged on that. What we see is that she still keeps the angles on the strike angles when we look into the left and the right side, which is still attacking with 0 degrees on the left side and keeping the 10 degrees on the right side, again probably due to the hip issues that we were talking about in general. And as such, we observe it and we assess it, but we have these things that has been so implemented into it, so we should take it into consideration, but trying to kind of reach a specific area or number of degrees here is not the outtake on it. It must be to having her awareness of the right hip. And of course, it can be an issue that your hip is always externally rotating and giving this kind of kinematic chain issue down to your landing. But she's as such not having any issues with it, so she has adapted very fine to it, and then we should keep it on. So that was the how to get it on here. So that is the last analysis that we did here in November 25th, and she will be here visiting me in February, and then hopefully we'll see that she's going on in a better level. So I'm having a bit of trouble getting it on to the next slide. Give it here. So
I can pull it up for you.
Yeah, I don't know why my computer suddenly exit. So it's actually the last slide is of it. So is it up? Yeah. Perfect. Perfect. So yeah, it's just the last slide. So we made it. Yeah, just for summing it up on this case and in general, in my opinion, when we work with running related issues or issues in general with people's body that are related to the mechanical state or their body as such, or especially or at least especially with sports people or active people, we must understand that for a major part of it, in my opinion, we have to deal with the laws of physics, the external forces that are providing or pushing into the mechanical unit of us, of our body, and understanding, of course, the biomechanics of our body and the anatomy and the physiology as such. So understanding the external factors and the intrinsic capacities is vital for giving us a path into giving us a clear understanding, but also giving the patient a good understanding of what is specifically going on, but specifically in this field, because we also have to ask about the habits and the behavior and how to work with these patients and the situations. And this again is specifically into the very biomedical or biomechanical aspect, taking into account the psychosocial issues are of course also very important, but in regard to this and this specific webinar today is regarding to the mechanic issue. We always take into account what is going on with this patient. Why is it so important to run so much? As for instance, for Lone, as the Adidas runner is a part of her social integrity, so it's a very important part of her life in general. So of course it's also something that we have to take into account. But when we take into that account, we are able to be very credible, and that is really one of the key components in this circle that goes around the dollar question. Understanding, having a high professional quality, understanding habits and behaviors, understanding all the things that are not only related to the body, but also into the behavioral science and also the psychosocial capacities, makes us very credible. And that, as an extra notice, is very much supported by tools like Digitsole Pro that gives us a very, very strong didactical tool for supporting our ideas and our plans for our patients, because they, in my experience, is that when they get a visual feedback, one is that we just present some feedback, but when they get it visually and they can see it on the screen that this is you, together, for instance, with video analysis, we really kind of sum it up, and we give, and in regard to, as patients' problems are often multifaceted, we also give a multifaceted treatment habitat or plan for them. So we kind of balance the etiology and the interventions that we are giving. So that is my take on how to address runners or in general sports people. So that was that from me. I hope you understood my English and the idea of my presentation.
Thanks, Ivan. I think Brandon, I'll jump it back to you to just kind of go over a little bit more specifics of the technology and the company briefly, and take if anyone has questions, please just throw them in the chat box and Brandon will answer them for you.
Thank you. Yeah, look, Ivan, great job. We understood you perfectly well, and really good case study. Appreciate you sharing your expertise on this. So, guys, little background: who's Digitsole and Digitsole Pro that he's speaking to. So, new technology that recently was started in France and now is moving to the US. In fact, we officially launched on Monday, so very, very new. But this idea of basically a sensor-based insole that is AI powered, that has a very specific algorithm that helps to see to feed back to you some of the data that Ivan was so kindly to share with us. So if you could just kind of go to the next slide for me, that would be fantastic. So the idea is really also creating both an objective benchmark or baseline, if you will, and being able to see progress. And as you can see with Ivan's solution that or case study here, you saw a very specific set of progress, and he was able to monitor with different shoe deltas and other rehab modality deltas that showed progress of the patient, and it giving you basically an insight or a scope into a patient through technology to complement your eyes or your hands or anything else. So that's the fantastic part of what we do. And it's obviously for those who are in good health and those who might be facing health issues, we've got a solution that kind of helps you to either benchmark it or for both healthy and those who are struggling to improve. So go ahead and go to the next slide for me. And just to give you kind of an idea what he's talking about with the solution itself, it's actually a kit with 6 sets of insoles, 1 set of chips, and inside of that is you transfer the smart chip, and then you get access to the interface, which basically is all driven by Bluetooth via either a tablet or a phone or something along those lines, plus a web interface via your laptop. So basically, it's a very innovative kind of Bluetooth type of technology that pulls out roughly 22 different measurement parameters, depending on a combination of both run and walk. And we've also got a new rehabilitation module coming in the next few weeks that'll look at things like single hop, triple hop, side hop, center of mass jump, and some other things to kind of help further your objective standards in evaluating patients. So really think about it from a musculoskeletal standpoint, a return to sport, from a geriatric kind of neurological side of things as well. So we really can complement all of these different places and case studies. Okay, and last but not least, thank you for your participation. We look forward to doing some future webinars. If you have some interest and like to have either an in-service, be it done virtually or in person, feel free to reach out to us at, it's basically just sales@digitsole.com. And we will happily, reach back out if there's any additional questions or anything else for that matter. So open it up. Any questions? I haven't looked at the chat yet.
Yeah, and we'll send out obviously notification that the recording's been posted, but we'll also make sure the contact information for the company's in there if you want to set up like a specific, just to get more information on the technology or the cost for your clinic, those sorts of things. I know we're specifically, I work in arthroscopic hip rehab primarily, and we're definitely super interested in how we could incorporate this into our pre-op and post-op assessments of our patients to look at other parameters outside of what we can see visually and what some of our other technology does. And just to be clear, because this was really cool when I first saw it at the last show I was at, is that this is like a very simple small chip that the patient doesn't even notice the difference in the shoe insole. You just take out their shoe insole, put in the Digitsole insole, and then they just wear their own shoes. Or if you're trying out different shoes, you can look at different parameters. So I think that's obviously a really, really cool feature. You don't have to have a big special treadmill or anything outside of the patient's own shoes in the kit. So definitely let us know.
And one other thing I'll add to that, Ashley, is it's mobile. So you don't have to be in the clinic. You can be in any environment.
Right. So you can be on the soccer field, you could be, walking hills, those sorts of things. So really, really cool. I'm really, really excited to get my hands on it.
Yeah. To follow up on that, I think this case was really, really specific, and we did all the examinations on treadmill. But one of the things that we are using it very, very much for in our everyday practice with other patients is actually that we can put the sole in, and we just ask them to go out. Go unsupported. You just go out, go for 2 minutes up the road and come back, and then we will support them. Because one of the issues that we're always discussing when we're discussing clinical trials is that, well, it is a clinical trial, so people are often a bit biased maybe of the setup. So but in this situation, we are so close to an unbiased situation. Even if we could show them, if we could avoid them for knowing that the insole was in, but it's so close to what's actually going on. And yeah, I think that is really one of the keen perspective of having these insoles, that we are so close, and the patient also feels that there's nothing interfering with them in their walking, and they are not supposed to walk in a specific way or something like that. So it's really good.
Yeah, that's great. Well, if there's I don't see any other questions or anything coming in. Like I said, we'll get that information out to everyone via email. You can always reach out to us directly at IJSPT for the contact information. And we look forward to hosting you guys on some future webinars, and excited for your launch. Congratulations in the US.
Thank you. Absolutely.
And thank you again, Ivan, for taking your very, very late evening where you are to educate us and give us information.
Yes, absolutely.
So,
yeah.
All right. Well, everyone enjoy your evening.
Thanks, everybody. Have a good evening.
See you soon. Thank you so
Take
much.
care.
Bye now.